Hello, everybody. Thank you for joining us tonight. We're going to go ahead and get started. I'm Hannah from marketing, and I'm going to introduce Dr. Edwards. She's here talking about hypertension and pregnancy for our Better Birthday campaign that we just launched. I'm going to go ahead and introduce her and then let her have the floor. Dr. Edwards is a native of Riverdale, Georgia. She enjoys traveling and fine dining. She graduated from Mercer University with a Bachelor of Science in Biology in 2004. And in 2009, Dr. Edwards graduated from the Philadelphia College of Osteopathic Medicine, the Georgia campus, with a Master of Science in Biomedical Sciences. She graduated as a Doctor of Osteopathic Medicine in 2014 from the Philadelphia College of Osteopathic Medicine. She completed her residency at St. Joseph Mercy, Oakland, and Pontiac, Michigan in 2019 and joined Carrollton Obstetrics and Gynecology the same year. She is passionate about women's health and serving her community. Dr. Edwards also resides in Carrollton with her husband and her 2 kids. Dr. Edwards, whenever you're ready.
All right, thank you so much, Hannah. Like she said, I'm Dr. Edwards, and I'm an obstetrician and gynecologist here in Carrollton. And I'm so excited about this webinar series that has been started, the Better Birthdays. And so today we're going to talk about something that's very common in pregnancy, and just common in general, actually, which is high blood pressure or hypertension. But we're going to talk about how it can affect pregnancy outcomes. And the point of this is so that you are better equipped with knowledge and knowing the signs and symptoms, so that when certain things are happening, you're able to know that, okay, this is normal or this is not normal. I need to reach out to my physician. The information that I'm discussing with you is just kind of like generalized for the population. This is not specific medical advice for any one person. But like I said, this is just so you'll have some information so that you will be more equipped with knowledge to have that conversation with your physician when you're making those shared decisions in your plan of care. Okay, so this is, if you have to ask a question, you can click the button and those questions will go to Hannah and we can get those answered, okay? So again, I'm Dr. Shatia Edwards. I'm at Carrollton Obstetrics and Gynecology. There's actually 2 OB-GYN groups in Carrollton. One is the Tanner group, and I'm with Carrollton OB-GYN. Both are affiliated with Tanner Medical Center, and there's our website if you want to look us up. Okay, and so like I was saying, today we're going to learn the differences between different types of hypertension, different types of high blood pressure. So chronic high blood pressure, meaning you've had it, prior to pregnancy. Then we'll talk about gestational hypertension and preeclampsia. We're going to talk about the risk factors so that you'll know what is normal, what's not normal, what needs to be brought up at your next doctor's appointment or sooner. And then we're going to also identify some of the signs and symptoms and understand why it's so important to have an early diagnosis and treatment so that we can have better outcomes with our pregnancies. So these are the different types of hypertension in pregnancy. So you can have high blood pressure prior to you being pregnant or early in pregnancy. That's identified. We'll go a little bit more in detail in the next couple of slides. And then there's gestational hypertension, where you have high blood pressure that is associated with the pregnancy. Preeclampsia, we'll talk about some of the warning signs of that, and then what we're ultimately trying to avoid with the high blood pressures in pregnancy is eclampsia. Okay, so chronic hypertension is when you have high blood pressure before you become pregnant, or it's identified prior to 20 weeks of pregnancy. So normally when you get pregnant, there's normal physiological changes that happen. So the blood vessels in the body have less resistance. So it's normal for your blood pressure to decrease a little bit when you're pregnant in the first and early second trimester, and it kind of goes back to its normal values, late second trimester, third trimester. So sometimes people who do have chronic high blood pressure or chronic hypertension, it may go undiagnosed because of those normal physiological changes that occur during pregnancy. So that is also why it is important to make sure that you are healthy prior to going into pregnancy, making sure that you're getting annual exams with your primary care physician, because if that's the case, then they can pick up on some of these diagnoses that some people don't even know that they have until they become pregnant. So even with chronic hypertension, it does increase the risk of progressing to either gestational hypertension, preeclampsia in the second or third trimester. So that's why it's really important to have an early diagnosis so that we can watch those blood pressures more closely, do more frequent labs if necessary, do more frequent blood pressure checks or office visits if necessary, so that we can catch it before it starts to become problematic. This chart is just some of the definitions from some of the various medical societies. So at the top, you'll see 2019 ACOG guidelines, where they're a little less stringent in the diagnosis of high blood pressure. So really in pregnancy, we start to get concerned when that top number or the systolic blood pressure is greater than 140 and the bottom number or the diastolic number is greater than 90. But you can see here that some of the other committees start identifying elevated blood pressures at greater than 120/80. Okay, so the second category is gestational hypertension. And so that is defined as when you have those elevated blood pressures greater than 140/90 toward the end of the pregnancy. So blood pressures aren't starting to elevate until after that 20 weeks of pregnancy or closer to the due date. The main difference that we'll talk about between gestational hypertension and preeclampsia is having protein in your urine or proteinuria. So with gestational hypertension, we just have the high blood pressures without really having any abnormalities in the labs or having protein in the urine or having these signs and symptoms of preeclampsia that we're going to discuss in the future. Most of the time with gestational hypertension, those cases will likely resolve after delivery, unless it's a situation where maybe it was chronic hypertension, but because of the physiological changes in pregnancy, the blood pressures didn't start to elevate until after 20 weeks. And so sometimes in those situations, the high blood pressure may continue after pregnancy because it was an underlying chronic hypertension that was going on. But then some people, so that's what I was just referring to. So some people do have a high risk of developing chronic hypertension even after pregnancy when they've been diagnosed with gestational hypertension. Okay, and then we have preeclampsia in pregnancy. So this is when we have elevated blood pressures after 20 weeks of gestation and we have protein in the urine. So you may notice that every time you come to your doctor's visit, we always ask you for a urine sample. And that's one of the reasons why we're checking to see if you have glucose or or protein in your urine, because we want to evaluate for these disorders or these diseases that can develop as pregnancy progresses. So preeclampsia ranges from about 3 to 8% of pregnancies. So on average, about 1 in 25 pregnancies would have some form of preeclampsia or hypertension in the pregnancy. And so what we are trying to do by identifying preeclampsia early in pregnancy is preventing it from progressing to eclampsia, which is having seizures in pregnancy, which could lead to other comorbidities as well. So with preeclampsia, it can affect many organs, and so we're going to discuss that as well. So some of the signs and symptoms of preeclampsia that we discuss with you when you're coming to your prenatal appointments to kind of look out for, but sometimes some of these symptoms can just be associated with normal pregnancy, just, you know, nausea or vomiting, things like that. But when I'm talking about these symptoms, I'm talking, you know, symptoms that you're having, that you've tried multiple, you know, remedies for, and it doesn't change. So one of the common signs of preeclampsia is a headache that won't go away. So you have a headache. It's usually like a frontal headache. Sometimes, you know, people will describe it as feeling like a tension headache, but you've tried Tylenol, you've, you know, you made sure that you were hydrated, you know, you had more than 60 ounces of water, you turned the lights off, you tried to take a nap, and that headache still won't go away no matter what you do. Definitely worth calling your physician to see if you need to be evaluated for preeclampsia. Another one is changes in vision. So having spots in your vision or having like little floaters in your vision, feeling like you have double vision or things like that. Of course, making sure that like you're, you know, don't require glasses, or you don't have any, you know, vision issues prior to pregnancy, but definitely acute changes in your vision can be associated with preeclampsia as well. Can also cause fluid to build up on your lungs. So some people, their presenting symptom may be trouble breathing. And this isn't just, okay, you know, I'm in my 3rd trimester of pregnancy and I just climbed up the stairs and I feel a little winded. This is just cannot catch my breath. Even when I'm just sitting on the couch or just standing still, I just can't catch my breath. Also, very, you know, a warning sign that you need to be evaluated. So the sudden weight gain, it's more of a soft call. It's not one of like the primary symptoms, but it definitely can give us warning signs that preeclampsia is brewing there. So we're talking about more than, you know, 3 to 4 pound weight gain in a week when your diet hasn't changed much, or a lot of lower extremity edema, like the pitting edema, that isn't resolving when you are sitting and elevating the feet and it's not going away. Same thing with like swelling of the face and hands. So those are some of the signs and symptoms that can be normal just in pregnancy, but sometimes in combination with some of the other signs and symptoms can lead us to a diagnosis of preeclampsia. Pain in the upper stomach, the reason why that is associated with preeclampsia is because preeclampsia can affect the liver, and that's where your liver lives. So sometimes when you're having pain in that right upper quadrant, or like feeling like epigastric pain or heartburn or GERD symptoms that doesn't go away when you take your Tums or your Maalox or your heartburn medication, that could be a signal, as well as nausea and vomiting. So some people are more at risk of developing preeclampsia. So a first-time mom has the risk of preeclampsia. If you've had preeclampsia in a previous pregnancy, it puts you at risk of preeclampsia in subsequent pregnancies. Like we said at the beginning of the presentation, having high blood pressure prior to pregnancy or early in pregnancy increases your risk of developing to preeclampsia. If you're pregnant with twins or triplets, that can increase the risk of preeclampsia, as well as advanced maternal age. And I know that term just seems so unfair, but that's a pregnant woman over the age of 35. And then one risk factor that a lot of patients aren't aware of is when you become pregnant by assisted reproductive technology, so like IVF, that also increases the risk of preeclampsia. Excuse me. having diabetes prior to pregnancy or diagnosed with gestational diabetes, that can increase the risk. Obesity, meaning having a pre-pregnancy BMI greater than 30. Some autoimmune diseases like systemic lupus and having chronic kidney disease. These are all risks of preeclampsia. And so when you go to your prenatal appointments, it's very important to reveal or divulge these risk factors with your physician. So if they're asking you about these risk factors, these are the reasons why we're asking you about past medical history so that we can screen for risks of different disorders and diseases of pregnancy. And a lot of them, if they can be properly managed prior to pregnancy, can help us, reduce those risks of developing events during pregnancy. So one of the biggest questions I get is like, especially when there has been a previous diagnosis of preeclampsia or high blood pressure, it's like, what can I do to prevent it? Overall, it's really not too much that you can do because preeclampsia has more to do with how the placenta forms and how those blood vessels from the placenta form and the constriction of the blood vessels. So a lot of it is just physiology and it's just the way your body is made. But there have been a lot of studies for the past 30 years that have evaluated different methods to try to reduce the risk or prevent people from developing preeclampsia. So various vitamins such as vitamin C, vitamin D, vitamin E, fish oil, garlic supplementation, folic acid supplementation, restricting the diet from sodium, that could probably help with like chronic hypertension. But as far as preeclampsia, and these studies have not shown a significant difference in the patients who develop preeclampsia versus the patients who don't develop preeclampsia. So to date, there's no specific intervention that has been proven to eliminate the risk of preeclampsia. A lot of people thought that like, okay, well, if you just go on bed rest, well, then maybe my blood pressures will stay a little bit lower. So that way I, decrease the chance that I get high blood pressures in pregnancy. But again, when we're talking about preeclampsia, we're talking about physiological changes that are causing the elevated blood pressure. So bed rest is actually not routinely recommended. Of course, in very specific situations, it may be, but routinely, we're not recommending bed rest because ultimately it's just increasing your risk of developing blood clots. And so the risk the benefit of bed rest isn't, outweighing the risks of it. So that is not routinely recommended. But one of the most promising ways, especially if you have risk factors that we discussed before, or if you've had like a previous pregnancy with high blood pressure, you have chronic high blood pressure, is actually a baby aspirin. Because again, preeclampsia and eclampsia is thought to be associated with how those blood vessels form. So by using aspirin after 12 weeks, that has been shown to show a modest reduction in preeclampsia with severe features. So not much of a difference in the patients with chronic hypertension or gestational hypertension, but definitely showing a reduction in patients with preeclampsia with severe features. And so those severe features that I'm talking about are on the previous slide, these symptoms that we were discussing. So the best benefit is to start the aspirin right at 12 weeks, but before 16 weeks has the most benefit. And then you take that throughout the pregnancy. So, okay, so we've been talking about high blood pressure, we've been talking about some of the signs and symptoms, but why does it matter? So why do we make such a big deal about preeclampsia and high blood pressures in pregnancy? Well, it affects mom, it affects baby. So I didn't want to go into too much, physiological or an anatomy and explaining this, but basically preeclampsia affects almost all of the organs in the body. So we can have vascular changes. So that's where the vessels are constricting and causing blood pressures to increase. We can have pulmonary changes. That's what I was saying before, like some people present with shortness of breath because fluid may be building up in the lungs. It can cause hematological changes, and that's a subset of preeclampsia that we won't really go into detail about, but it can cause decreased platelets and affect that. It can affect the liver, which is hepatic changes. So, we talked about that right upper quadrant pain and elevated liver enzymes. And then it can also affect the kidneys, and that's what we were talking about with the protein in the urine. So if these are left unidentified, we could have some permanent damage to mom if this preeclampsia is not properly identified and treated. And then how does it affect baby? Well, if mom's blood vessels are constricted, then we are impairing the uteroplacental blood flow. So uteroplacental means the blood flow from mom to baby. So if baby's not getting enough blood flow, then it can cause baby not to grow appropriately. So we're talking about fetal growth restrictions. It can cause oligohydramnios, which is a low amniotic fluid. It can cause placental abruption, where the placenta starts to come away from the uterus prior to the baby being born. But one of the biggest things is that a lot of times when we are diagnosing preeclampsia, we're either medically inducing a patient in order to treat the preeclampsia, or sometimes moms are going into spontaneous preterm birth. And so that can affect baby because, of course, we want baby to be able to develop until full term. But sometimes babies, when they are spontaneously born early or medically induced early, they may have some complications with being born too early. So how do we treat preeclampsia? So the biggest thing is just early identification. So we're going to be monitoring blood pressure. Sometime we'll send you home with the blood pressure monitor to monitor blood pressures at home. Depending on if it's with or without severe features, we might start a medication to keep the blood pressure at a more normal range. And sometimes, depending on the severity of the preeclampsia, the way to treat it is just to deliver, and that in a lot of cases is going to resolve the signs and symptoms that are associated with preeclampsia. But the biggest thing is just knowing what the signs and symptoms are, knowing what's normal, knowing what is abnormal, so that you can have that conversation with your doctor. Because early in the pregnancy, we're seeing you every 3 to 4 weeks or 2 to 3 weeks. And that's also the reason why we see you more often as your pregnancy progresses, because some of these disorders associated with pregnancy are more likely to develop in the late second trimester or third trimester. So sometimes earlier in the pregnancy, when the appointments are a little bit further apart, when we're not seeing you as often, that way you'll know the signs and symptoms and know, okay, well, I know my next appointment isn't until 3 weeks, but I'm experiencing this. So I think I may need to call my physician to see if I need to be evaluated sooner. So that was the information I had about preeclampsia. So if there are any questions, you can submit those. But I just wanted to mention about Better Birthdays. This is Tanner's new initiative to keep moms and babies safe during pregnancy and beyond. We consider the postpartum period up to 12 months after delivery. So there's a lot of different webinars that are going to be coming up in the future. So be on the lookout on the Facebook page and all of the social media pages to get more information about that. And also wanted to discuss some of the classes that are offered here at Tanner. So there are some prenatal yoga, pregnancy boot camps, baby care boot camps. That is also on the website so that you can get more information and sign up for those classes. And these are the the social media for you to follow. But again, don't forget that there are two groups in Carrollton. One is the Tanner Healthcare for Women, but there's also Carrollton OBGYN. We're located at 156 Clinic Avenue, and our number is 770-214-BABY, which is 2229. But then there's also the way to get in contact with Tanner Healthcare for Women. And that is our group. We are associated with Tanner Medical Center. That is how you can make an appointment with us. There is pictured the physicians that are, and the nurse practitioner who's associated with Carrollton OBGYN. And there is our website if you want to visit us as well. So you can visit our website, visit Tanner's website, because they have a lot of great programs that are being offered to have healthy babies and healthy moms and successful pregnancies and deliveries. So if there are any questions, I can take those now.
Dr. Edwards, you did have a couple come through.
Okay.
The first one was, can you have a natural birth if your blood pressure is high?
Yeah, that's a very good question. So yes, you can. It depends on a couple of situations. So if your blood pressure is high, but we can manage it with oral medications, then yes, we can induce labor for a natural birth, and by natural birth meaning a vaginal delivery. But sometimes in the process, especially with our first-time moms, when there is a very, sometimes an induction can take 24 or 48 hours. And if in that time the blood pressures continue to worsen and we continue to give oral medications and IV medications and the blood pressures are not improving, and we're seeing more of those signs and symptoms and changes in the labs, sometimes we will have to expedite delivery, meaning proceed with the cesarean section. But the goal would be to have a healthy delivery vaginally, but the ultimate goal is to have a healthy mom and a healthy baby. And so sometimes that means expediting delivery by doing a cesarean section. But you can absolutely have a vaginal birth even with the diagnosis of preeclampsia and high blood pressure.
Okay, and another one that came through was, is exercise okay for me if I have hypertension and am pregnant?
Yes, so if you were already exercising prior to pregnancy, you can continue to do what you were doing. Just, listen to your body, make sure your heart rate isn't getting too high, make sure you're not feeling lightheaded or dizzy. And if you hadn't already been exercising prior to pregnancy, you can still do, some light cardiovascular, walking or something like that, 30 minutes a day, at least 3 times a week. So yes, that is okay to continue to do even if you have the diagnosis of high blood pressure.
Do you recommend exercise as a way to fight off these complications, or are they a risk?
So not necessarily to fight off the complications. Maybe if the diagnosis is chronic hypertension, then exercise is going to help. We don't recommend that you lose weight in pregnancy, but cardiovascular exercise is good for heart health. So that is going to help with that. But as far as exercising to prevent preeclampsia, that that probably isn't the reason for exercise, more so than just heart health. These are good.
Okay, and somebody else was interested in knowing if they could take a low dose of aspirin to help prevent preeclampsia.
So I would definitely discuss it with your physician so that they'll know what your specific risk factors are, and make sure that there's no reason not for you not to be on a baby aspirin. But generally speaking, that can reduce the risk of preeclampsia, but I'm not giving, medical advice. You definitely need to speak with your physician and see if that's the right decision for you and your particular situation.
Great, thank you, Dr. Edwards.
You're so welcome.
And then somebody also is interested in knowing if they should get the COVID-19 vaccine if they're pregnant.
So ACOG does recommend the COVID vaccine for patients who are trying to conceive, patients who are currently pregnant, and who are lactating. So it's a shared decision. I understand some of the reservations. There are no specific studies on pregnancy and the COVID vaccine, but there have been, quite a few people who were in the studies and became pregnant, and so far there haven't been any adverse outcomes. And the mechanism of action of the vaccine, there shouldn't be any complications with that. So yes, we do recommend the vaccine even in pregnancy if that's what you choose to do.
Okay. And then your last one was, if you had complications with an early delivery, will you likely have them with subsequent pregnancies?
It's possible, and so that's why if you did have complications with the previous pregnancy, that's why it's imperative to get early prenatal care, and even more imperative for you to make sure that you are at your best health prior to getting pregnant. So if it was complications because of high blood pressure or diabetes, the best thing is to get all of those comorbidities under control prior to getting pregnant, and once pregnant, establishing early prenatal care so that we can get those baseline labs and do any early interventions that are necessary. But not always will you have the same complications or the same difficulties with pregnancy, but if we're able to establish care early, then we're able to intervene early and try to do those tasks that can reduce those risks.
Well, that was all we had tonight. Dr. Edwards, thank you so much for joining us tonight.
Absolutely.
And all of our attendees, thank you for getting on. We appreciate it. Please continue to check out our classes on tanner.org for more informative topics, and I hope you all have a wonderful evening.
Okay. Bye-bye. Thank you.